The Principal Secretary for Public Health and Professional Standards, Mary Muthoni, is our guest for the next hour. Good morning, PS.
Good morning.
Karibu sana.
And how are you?
Very well.
Are you feeling okay? Have you taken care of yourself? Or can I take care of you right now?
Felaris alikuwa na kahoma last week. Akasikia unakuja ikapona.
Ikakuogopa.
Kahoma sometimes will just, maybe it's just fatigue.
Yeah. Or probably tired. It's just fatigue. I think that's what she had.
Dehydrated. You just need to take some water,
Okay.
And you'll get better.
Homas are squeezy.
So,
way.
Sometimes you don't even need medication, probably. Yeah.
Anyway, karibu sana. We're going to talk about, all these issues of public health. We have had various outbreaks that are being monitored. Marburg, Ebola, this and the other. Uganda has declared the country Ebola-free.
Yeah.
I don't think we have to declare ourselves Ebola-free if we didn't have Ebola at all. Or did we? Maybe she'll tell us.
We didn't
but
know.
before we get there,
Phalaris
is going to give you the day's quotes.
Karibu sana.
Thank you very
Today's
much.
quote is courtesy of a French novelist, André Gide. The quote reads, "You cannot discover new oceans unless you have the courage to lose sight of the shore." You cannot discover new oceans unless you have the courage to lose sight of the shore. How do you interpret that?
You have to get through or face challenges so that you can unravel new issues and resolve them. And I think that is what the health sector is about. Every day, it's like an emergency place. When one ambulance leaves, another one comes in.
Yeah.
And you have to keep taking in the patients, however injured they are. That's what I think. And in the country, really, you'll never miss a challenge here and there, whether it is in terms of agriculture, housing, or any other aspect that is there.
Yeah.
Therefore, as a government, we must keep soldiering on and ensuring that the citizens are comfortable and the citizens are receiving, the benefits that the government can give in. But we have to keep digging and moving away from the shore. And not fearing the tides that may come with it.
All right. P.S., let's start with the most burning issue, or shall we say the most hemorrhaging issue. Ebola.
Yes.
What's the Ebola situation in this country at present?
First and foremost, we do not have any Ebola case in the country. Although we've had suspected cases. In suspected cases, is when we get somebody at the ports of entry, maybe you have some hiked fever, and maybe you have some woods, and we suspect probably you could be suffering from the same. And we put you aside and tell you, please get to be seen. So we do not have any confirmed case in our country as at now, whereas our neighbors have had hundreds of them and even deaths. But I think we have been able to manage within the country and also at the border because of also the collaboration that we've had with our neighbors, ensuring that our healthcare workforce are training together, and we are also keeping standards. We do not have screening in Kenya, and there's no screening in Uganda. We've had to work together at the one-stop border. Also, we have had to ensure that people are aware. So we've been pushing risk communication out there in the community, just to ensure people know what needs to be done. If you're coming from those countries, please even present yourself in the health facility just to be seen. Again, we have also increased a lot surveillance at the ports of entry, and surveillance is an everyday issue in the health sector. Whether there is something that is happening or not, we do surveillance every day. We've improved on coordination between the national government and the counties because health is a devolved function again, ensuring that they are activating their emergency centers, and especially the ones that were used during COVID. Because during COVID, we built in a lot of structures, whether it is software or hardware. And those structures are still in place. The only thing that we needed was to activate them and ensure they are operational. And equally, the government has moved into chipping monies here and there for public health to ensure that we are able to keep rolling. Because public health issues is not just about Ebola. It's only that Ebola was highly publicized. The death rate is usually higher than any other disease, than even Mpox, which is still in the country even now. We still have Mpox. And we have had about 19 deaths out of Mpox. We've had cholera, we've had dengue fever, we've had many other public health events that have been seen in the country. However, we are happy to also hear that there's no more Ebola in Uganda, and that gives us a bit of rest. Not rest really, but a bit of ease in regards to also how we are managing. But
so are we stopping our
surveillance
surveillance at the border?
Sorry?
Have we stopped our surveillance at the border?
No.
Now that there's no Ebola in Uganda.
We have actually not stopped because we still have Ebola in other parts of Africa. Who are also our neighbors like Congo. So we cannot stop surveillance because Uganda has gone down on the numbers. No, we will keep doing surveillance. And by the way, even the wastewater for our aircrafts, we keep checking and taking to the lab to check on the pathogens, because that also gives us the patterns of the likely diseases in the country. You can get on cholera, on Mpox, on Ebola, and that shows us how we have improved on our testing capacity since COVID times. During COVID, we would get one sample and take it to South Africa, to the UK. But right now, whether it's Ebola, whether it's Mpox, we test it here. And within a period of 6 to 8 hours, we are able to get the case, whether it's confirmed or not. And that's why we've also been able to move steps really quickly to array fears from the members of public and also ask them to keep calm. Because if you also give a lot of fear to members of the public, you can't even function. They'll think that it's COVID, that it's spread through air, and they'll stay at home or start wearing masks, where else it's a different disease all the same that is contracted through contact, body contact, fluids, it's not because we'll eat some food together that you get Ebola. So that is the status in our country, and we thank God that we still do not have a case, but that does not mean that we keep down our tools. We need to keep reminding the members of public that keeping high levels of hygiene, both at the household, both at the workplaces, both in social areas, is what will keep these diseases away in our country.
Was there a case of Ebola, not of a Kenyan, but a case of an Ebola, a suspected Ebola case that was brought into the country, into any facility in the country?
That was normal suspected cases. Sometimes when hospitals find that the person could really be really sick, sometimes they can suspect, 80%. But anybody who was suspected, all of them turned negative, including the one you could be highlighting from
the Americans who
Kiambu Road.
The Americans who may have come to Kenya tested negative.
Anybody who has been brought to Kenya has tested negative, whether it is an American or a Kenyan or a Ugandan or any other. And we do not have patients labeled Americans and Kenyans. When you're a patient, you're a patient. We don't keep going now and saying and segregating.
Well, you know whether they're American or Kenyan.
That you're American. Or, yes, that data is going to be there, but you're a patient. So it is not right to now keep going deeper that this is the American, this is the Kenyan. If you're a patient, you're a patient. So let us treat the patient.
Are they still in the country?
Who?
The Americans.
And who are those? And when did they come?
The Americans that you've mentioned.
Which Americans? You need to give me more details. I have had a lot
any
of
person who was brought into the
rabbit
country.
stories there.
Was there any person brought into the country?
I have had a lot of rabbit stories,
surveillance,
which I need to clear.
Okay, please do.
Because number one, just last 1 or 2 weeks ago, and people kept asking if the quarantine center is still going on, if there are Americans who have been quarantined. Really, guys, and let me tell you, one, when the courts declared that the Laikipia Airbase quarantine center should be stopped, we stopped. So any other story after that, unless somebody brings me evidence that something is happening, I would really not know. Because if the court has said stop, you stop, and that ends there. Number two, I want to say categorically that Kenya in itself, at one time, will require either isolation centers or quarantine centers in every of the counties that we have. Already, we are trying to ensure that the isolation centers that we had during COVID are up and running. Because should we be hit, where will we take our brothers and sisters? Forget about the Americans. Let's talk about Kenyans. Where are they going to be taken to? Should we confirm that this is a case? And I want to also say there's a difference between quarantine and isolation. When you quarantine somebody, it doesn't necessarily mean that the person is sick. It's only that that person is exposed. And when you're exposed, you could even be the doctor who was serving a patient who is a confirmed case of Ebola or any other disease. But when we isolate you, it means now you are on a medication. So those two are different. And what was being proposed was a quarantine center in which, even in our counties, every of the counties may require each. Therefore, positivity around public health issues, because when this city succeeds, when this government succeeds, when issues of healthcare succeed, we are all winners. So I always ask people, let us not try to politicize anything around the health sector. Let's look at issues. If the government is not doing something, then we are able to rectify at any given time and guide the members of public vis-a-vis when there is something good that can benefit the members of public, and we are all pushing back. So, and the media has the loudest mouth. Join me in this campaign. It will help.
All right. I've got a few questions, and we'll get to Mpox in a minute, but I wanted to know about our screening and our processes, actually beyond screening. It was how many 26,000 people who had at some point, CS Duale had mentioned, 26,000 people had been screened at our ports of entry.
We have more.
And I know over time that number has increased quite largely. But then the question is, okay, you get screened at a port of entry because you're coming in from a country that probably has a high risk of, not a high risk, or a risk of Ebola. That's okay. But it's a virus that also incubates, and I think we spoke to PS Oluga and he said the incubation period for this one is longer, 21 days. What happens now beyond that? Because, someone could just be asymptomatic, coming through a port of entry. What was the follow-up and the continuation?
If you go to, let me give an example of JKI today. We have a software that is self-screening, and you'll go through the questions and answer. And even after you leave the airport, the port health officers will keep following you, going by the answers that you give. And we have your data. So it does not end there. Within the period of 21 days, we keep the surveillance to see these people who have already left, and we keep nudging them, because sometimes self-screening is also very important. They'll ask you if you have fever, if you have stomachache, and should you need help. We also give you information on which areas that you need to to get help from. So screening does not just end that day. We continually monitor our teams, and we also encourage the members of public. This is also self-discipline. If you feel that you're unwell, do not stay at home. Please run to the nearest health center. And we also do tracking and tracing of individuals. If we see like there's somebody who's really been unwell and we suspect this is Mpox, this is Ebola, then we also track the number of people that you have come across. And willingly and voluntarily, we request them to go to a facility so that they can also be tested. So this is a continuous process, and it also calls upon the kind of communication that we relate to the members of public to get awareness, to also be ready to go to the hospital, not because you are confirmed, but just to clear the air that you're okay.
Okay. And now the Mpox question. You spoke about several cases in Kenya, 19 deaths. It may be that we are scared of Ebola and
something else.
Yeah, there's something else.
Is Mpox was declared as a public health of emergency some time back. And we closed that chapter equally. Okay. So that means globally, and even in Africa, it is not really a public health emergency of concern, that it can be managed. That is why we have also not been loud about it. Then Ebola came and it was declared that of emergency concern.
Right.
And that is when you keep a focus, because you know that there's a high or a likelihood of many people contracting. As Mpox right now, it's on management level. We can be able to talk to members of public, keep high levels of hygiene, wash your hands, just like cholera and other public health events. But we keep insisting, hoteliers, keep high levels of hygiene. Ensure that the beddings that one person has slept on do not allow another person to come and sleep on. For the truck drivers who are crossing many boundaries coming into the country, when you get into the country, ensure that your health is okay. Go for screening in the hospital. You don't have to wait until you have fever, but just voluntarily go for screening on these type of diseases, and also commercial sex workers, you know, because we know the minute you get into contact with somebody who has Ebola or Mpox, then you will get it also. Take care and take care of yourselves. So really, what is remaining is ensuring that we have risk communication that keeps moving out on a daily basis, and also speaking to school-going children. If you have school-going children, ensure that they are also aware. When you get from the toilet, clean your hands. Before you eat food, clean your hands. When you're going home, mama, when you're going for baby showers, ensure you don't go touching somebody's baby with hands that you have not cleaned, or with clothes that you've been hugging everybody in the market. And because you are excited, you just want to hold the baby. Those are some of the discipline issues that we need to instill, called behavioral change. Yeah. And behavioral change is very low in our country, by the way. Infection prevention control is the lowest of the components that we have. Kenyans don't have a habit of washing hands. They don't have a habit of drinking clean water. They don't have a habit of wearing gloves if you're sweeping in your place or touching the sewage. They don't have that habit. You know, you'll find.
Is this habit or access? Because washing hands requires clean water. Drinking clean water requires clean water.
I agree.
Wearing gloves requires gloves.
I agree. That is a conversation. A different conversation all over. I am talking about even the ones who have access, even here at Nation Center, where water is in plenty. Ask any of these workers how many have washed their hands when they have come in, by the time they have come in. You will not find half of them. That's what I'm talking about. The issue of access of clean water is a different ballgame all the same, and it is not in the whole country. It's part of the country. Just like we say, in our country today, we still have 15 counties that practice open defecation. So why is it that there are families, even who have 100 people, and they do not have a toilet in their household? They go to the bush. Maybe they are pastoralists and they move from one place to the other. So they don't see the need of the toilet. Not because they can't have it, but the nature of their
Life.
is quite different. So those are some of the aspects we really need to look into as we are talking about public health. But on infection prevention control, this goes even up to hospitals. The nurse who is working on your, BP at the triage, did she wear gloves?
It's a very critical question. Yes, just hold that thought. We need to take a break, then we'll be right back to discuss cross-ministry coordination in terms of preparedness for any emerging issues, or we have El Nino rains that we've long been talking about, and also looking at workforce capacity within the health ministry. Stick around. We're with PS Mary Muthoni Public Health and Professional Standards. It's Fixing the Nation and TV.
Good morning, nation. Good morning, Kenya. I'm Caxton Shako. I'm a local tour guide in Taita Hills. Welcome to Taita Hills, the rooftop of Kenyan Coast. Today I'm here, we're fixing the nation, one walk, one hike, one adventure at a time. This is Voi in the farthest side between the two hills. That's Voi town. And, that's the whole of Voi area. That's Sagala Hill to the left. Then straight ahead, not so visible today, that is Kafigao, Mount Kafigao. That is Motaka town. Go to the east, then to the other side, go to Taveta, and now you come up to Mondani. And this is the view that you get when you're standing on one of the most beautiful viewpoints of Taita Hills, Mochora Rock. See you here when you come.
Fixing the nation, one walk, one hike, one adventure at a time. Thank you, Caxton. You're an amazing, amazing fixer, and we love to see and hear from people like you. Of course, Taita looks amazing, and we get at least to fantasize kidogo. Hata sisi labda tuko Taita Hills na tujui. Our number is 0769 590 762, 0769 590 762. Let us know who you are, where you are, what's working, what's not working, how you're fixing the nation, what's making you happy today, what's beautiful around you, what's making you unhappy. Involve us, in short. 0769 590 762. Easy as that.
Indeed.
We're back in conversation with PS Mary Muthoni Public Health and Professional Standards, and just getting to interrogate. When we hear outbreaks, it's it causes public panic, yes, but are we actually prepared for a lot of these issues that come about? Mpox, which could be a bigger threat than Ebola, but we're still also not taking away from what Ebola is. PS, the CHP programs that, we were having a chat just before the start of the show, and preparedness in terms of, the capacity we've built in our workforce and funding. Where are we with that? Across all counties, considering, again, healthcare being a very devolved function, can Kenyans fall back and say, we are 100% prepared for any kind of emerging issues, and we are able to address them at local level?
Well, there's nothing called 100% in emergency preparedness, because at one point you'll find probably there is a missing link. But I can confidently say we are at a place where we can be able to tackle emergencies that may occur in our country. One, the coordination around us in county governments, and earlier on I had talked about the software and hardware that we had built on during COVID-19, whether it is in terms of structures or in terms of the structure of coordination between county governments and national government. Since then, we have continually trained our healthcare workers. Between 2014 and from around 2014, we had healthcare workers who even went to West Africa to assist on Ebola. We still have that workforce here, who are more than 100. And continually, we have assisted others to join that cohort to respond to such kind of dangerous diseases. Again, we I have said earlier that surveillance is a continuous exercise on a daily basis at the ports of entry, and that is why I was talking about the wastewater from our aircrafts. You know, when people go to the loo in the aircraft, we pick that water, check on the pathogens that help us to detect the patterns of diseases and also the emerging issues that we could be awaiting for. Again, just to say that we are aware in terms of risk communication, pushing out to the members of public and ensuring that wash your hands at any given time. Most of the diseases we are getting right now and most of the outbreaks that we get right now, it's out of that levels of hygiene, which have really gone low. And we have to keep pushing for behavioral change of our citizens and the nation as a country, so that we can get it to other areas. As a country and as a government, we are focused more on preventive, promotive. And that is why the issue of community health promoters came in, to ensure that we reduce the number of ailments right at the doorstep of our houses. One, when the CHP comes to you, they will check your blood pressure. And we have trained them. They are local, but we have trained them. We have kitted them. We have given them a phone, and we give them a stipend at the end of the day. They'll check your blood pressure. They are able to check your blood sugar. They are able to check your children below 5 years on issues malnutrition and guide you what should happen or what kind of foods you need to give to your child. And they equally, there are very many women who get pregnant and think that they should not go to hospital. Kupata mimba sio ugonjwa. So they go giving them insights on why they need to go for prenatal care. And after that, they follow them up to when they deliver and after they deliver. Those are some of the basic issues that the CHP do. Currently, we have about 9.6 million households that have been registered across the country. And CHPs are distributed across the country. Each one of them, they serve 100 households. In Kenya, going by the latest data, from KNPS, each family has about 5 people, a normal or a basic family in Kenya. So we are about 12.5 million households in Kenya, and we've already been able to register 9.6 million Kenyans. And out of that, 48 million people even on repeat, because we have maybe 55 million, even on repeat. Like, I've come today and tomorrow I've come to check again. We've been able to check them on diabetes, go back to them, 11 million people again on blood pressure, checking if you're okay, coming back and asking, how are you feeling today? Can we refer you to the nearest facility? So that's the work of the CHP. They work with, because health these days is highly digitized. Even our CHPs have a phone, and they work with a system called Electronic Community Health Information System. It's called ICHIS. So ICHIS, when they take your blood pressure, they record that in Kangemi, I found a lady, I took her blood pressure. Then you have the status. Did you refer her to Kangemi Health Facility, or she remained at home because she was okay? That data comes to my desk. When it comes to the national office, we are able to look it through using our health economics, and we are able to also say, this area has a lot of people with diabetes. Maybe we should take a medical camp there and be able to push all of them to nearest level 2 facility to get tested further. Or should we buy more medication for this area or advise that particular county, because health is devolved.
Right.
Advise that particular county that this is the pattern in your county and you need to take 1, 2, 3 steps. So data is very important and is very critical. It also helps us in budget allocation and also defending budgets in parliament, both parliament, national government and county government. I know you saw the CHPs from Nairobi actually went to visit His Excellency the other day. If I may preempt what Latif wants to ask me.
Go on.
And indeed, this is just part of our motivation, because we are moving steps and we have introduced SHA for all our CHPs across the country. And that package is starting this financial year. So it was basically like a launch of our SHA activation for our CHPs, because it is also immoral that we have a CHP who is coming to your household, checking you whether you're okay, and they cannot access the same services that they are advocating for. CHPs, again, they are the ones who register people to the Social Health Authority. So we need a person who is medically and physically fit to serve Kenyans and ensure they are helping us to push the preventive, promotive agenda that the government has for the people of this country.
Just as a follow-up question, PS, 23,000 nurses are on strike. If anything was to happen, it catches us in a situation where we have a health sector that is already going through problems. And this has been a cycle. If it's not your clinical officers, it's your nurses that are on strike, it's the doctors. What is the ministry doing? Because...
Well, in many areas where you'll find there are different points of decision making, you're bound to get that, because 23,000 nurses could be on strike because of different governments. It's not a block strike, it's different counties, you know. And as a ministry, our work is to ensure that these nurses are trained and these nurses are, we are having a policy to be followed. Those are specific cases which I would say we follow up depending on the specific county, because they could not be on strike because of one specific issue.
These are 20 counties that are currently part of this strike.
Yes, and that's what I'm saying. We must go deeper into each and every county and find what is the issue that the nurses have with the particular government, quote unquote. And it could be issues of promotion, it could be issues of salary, it could be issues of retention. So we have to really narrow down on each county so that we get to know what can we advise the public service of that particular county to do to the healthcare workforce. Indeed, healthcare workforce is the backbone of any healthy nation. And we beseech that wherever there are strikes, that people sit on the table and agree moving forward how to deal with some of these issues. It could be return to work formula that has not been respected or honored, or it could be anything. I may not have all the details for each and every particular county, but that is a subject I would really love to discuss separately around healthcare workforce. We have about 42 cadres in this country, and not just nurses, starting from doctors, nurses, nutritionists, public health officers, and each of the cadre has a different issue to raise. From the ministry point of view, we deliberately have healthcare workforce as one of the pillars that we really want to cover. And you have seen in the recent past, the kind of noise that we had at Afya House has really gone down significantly. Maybe not 100%, but significantly.
What noise was that?
And that's... one, we had issues of internship, where the interns were against being paid 70,000, as opposed to what was in the agreement of 2016. So that we have covered. And this year we have sent or we have deployed 6,300 interns in our various facilities across the country. And secondly, it was from the Doctors' Union, where we had an agreement that they needed some increment some time back, and there was a backlog of almost 10 years, which we now covered and we are moving. Thirdly, we had different stakeholders or different cadres talking about career progression, talking about assigning CBAs, new CBAs, which is continuous. And the government deliberately created the State Department of Public Health and Professional Standards. Note, there is the word professional standards at the end of that State Department to particularly look into these issues. And that is why probably we have been able to handle specifically and narrow down to the issues that affect healthcare workers in our country every day. At the moment I know I am having something on the table about sending all cadres for internship, paid internship, which has not been happening. But that's a process because we have to go through Public Service Commission. We have to ensure that Public Service Commission approves the numbers that go for internship. But this internship all over, including the same Public Service Commission. So we have to have an engagement to see this is a budgetary issue. If public health officers have to go for paid internship, how much does it cost the nation? And how do we sustainably move forward with that?
Beyond this.
Yes.
P.S., sitting at that table where you look at all these professional issues coming up, addressing some of their grievances, the postings, the posting of interns, post-internship into registration, into then deployment. Do you think there's a case for having one unified national health services commission?
Well, this is a catch-22 because I'm a stickler of the law. And our constitution never created that. When they were creating the TSC, we never created one for
health services.
And should we even need it, we need a referendum to ensure that we amend the constitution for the same. I am a supporter of devolution. And really, let us not say that devolving the health services was a wrong thing, when probably it is the person running who could have a problem. So I think we need to really look into this in a very open ended space, so that and in open thoughts between county governments and national government, so that we agree, is it working or is it not working?
From where you sit, and I mean, I know health workers unions have lobbied for this, and conversations may be happening in Afia House and also with the Council of Governors. What are you hearing? Is there an increasing voice in support of a health services commission? This is not saying don't devolve health services.
Yes.
It is basically just
saying,
having
taken care of the healthcare workforce.
Have the healthcare workforce centrally employed and deployed. The services are then offered by the counties.
Basically, in a nation that is progressive, the most important thing is standardizing the welfare of the healthcare workforce. Whether it is in a one posting area commission or in different governments. We would not be having that noise if Homa Bay, Embu County and Mombasa County are paying their healthcare workforce at the same rate. I don't think we would be having that noise. So it is not about having a commission. It is about working on the standards of the healthcare workers in the country. And that is what we need to focus on. We might have a commission that is also going to be a pain for the healthcare workers. You know, don't cry for what you don't have, because you don't know whether it has spikes or not. I would really wish that anybody who is working within the healthcare gives ideas on how we can standardize the welfare of the healthcare workers in this country. Starting from internship, actually, starting from production to internship, to retention, to migration. That value chain must be taken care of. Remember, the biggest problem that we also have could not just be what the Ministry of Health has produced. We also have issues within Ministry of Health, Ministry of Education, because we also have production issues around that needs to be standardized. Yeah. Our universities, what are they training versus what we are training at KMTC probably. Those are areas, the conversation around healthcare workforce is larger than just a commission.
There was an institution that's under your ministry.
Yes.
That looks at standardizing this. I forget the name.
KHRAC.
KHRAC. Say it in full.
Kenya Health Human Resources Advisory Council.
Yes, that one. What work has it been doing so far?
Indeed, we work very closely from the ministry, and some of these areas, when I mentioned them, it is the contribution that KHRAC has done. Remember, KHRAC is an advisory. It's to tell the Minister of Health or the minister, this is where which way you need to go. Yeah. But at the end of the day, it boils down into all of us agreeing to one way forward. It's not really too bad because we can sit on the table and agree. It only gets bad when one party is not ready to agree. Yeah. So county governments and the Ministry of Health are in conversation on very many issues. And that is why you have also seen, at least we have made a move on the pending universal health coverage staff who have for a long time, 6 years on contract, and the government has given a budget of 9.8 billion to ensure these people are converted from to permanent and pensionable. Let's celebrate the small wins.
That small win is just taking too long. I posit that KHRAC was the government's actually hearing the concerns about the harmonization of the health workforce and their welfare and creating an institution that should lead into an amplified conversation around creating a health services commission. Now, if KHRAC is not well supported, resourced, well attended, then we will take longer
to do that.
You will obviously accept with me, PS, that KHRAC does not have the proper support. Does it even have an office? Does it have it has a board? Does the board have anywhere where it sits? It has a secretariat. Who sits in this secretariat? What work do they do? Are they permanent or are they just temporary?
I don't know what you mean by enough support, because Rome was never built in a day latif. Really, by establishing it in the first place is a step in the right direction. And we may not do everything at the same time, really. And I must say, by the virtue that there's a board, by the virtue that there are instruments for HR, by the virtue that we've been able to approve documents like strategic direction for the institution is a step in the right direction. That is what now needs to be defended, to be financed, to ensure that we implement it to the latter. Yeah.
We're just about to wrap up, but I wanted to ask
too early.
Finally, I know.
We are just starting.
Just getting started. But I wanted to know what the wastewater from our airplanes is telling us we should be looking out for. I think that was quite interesting that wastewater from airplanes coming in and out of the country is that's such a nice way of putting it. That's sort of, what is it telling us that we should be on the lookout for?
That's a bit technical. I may have to go back to the surveillance team to give us the nitty-gritties so that we know the highs and the lows.
The other way of putting putting it is, what should we be on the radar for as far as outbreaks are concerned?
Right now, we have Ebola, we have Mpox, we have cholera, we have dengue fever. At least for that.
Those ones.
Yeah.
What about our prevention? I mean, not prevention, but preparedness for El Nino?
Yes.
I know we had touched on it just a little bit,
Yes.
but as we wind up.
El Nino has a wider committee that deals with it under the Deputy President's Office, and which we are part of. The Ministry of Health is part of. And basically, we've also been able to subject ourselves into checking what is ready. We are not going there as freshers. We are going there coming from a point of knowledge. So we already have the data, we already have what we require, and we have already given advisory on exactly what we expect from the healthcare point of view. May it be in form of structures being destroyed, hospitals, to say per se, being destroyed, and we have to rebuild others, or have some, semi-permanent facilities that have to be constructed in sites where people will be, or may it be in the outbreak of waterborne diseases. We have to be cognizant of that. So we have to be ready with tablets, water tablets that need to be given to the people across. And, diseases like malaria, the outbreak of, malaria. Already, I know we had ordered for mosquito nets in readiness, so that as we get closer to that, we can be able to distribute. Global Fund has been a very big supporter on malaria, HIV, and TB, and we distributed the last financial year 15 million nets along the lake region and other high risk areas on malaria. So this, we are ready, and we will continue coordinating with other ministries so that we can make sure that, because there comes issues of security, when people move away from their homes, you can see issues of rape cases can happen, in the process. Children having malnutrition, you see. So gender-based violence because of frustration. So it's a multi-stakeholder issue that cannot be resolved by the health sector alone. And that is why I'm proud to say that the coordination mechanism that the government has put in place is one that is going to serve Kenyans when the right time comes.
Thank you, PS. Mary Muthoni is the Principal Secretary in the State Department for Public Health and Professional Standards. We've been talking about just public health. Right? Remember, wash your hands.
Just say personal hygiene, environmental hygiene, water and sanitation. Those are the three areas that Kenyans must always think about. So wash your hands every day. Ensure that your environment is clean, including these surfaces that we are touching. And ensure that you use your toilet properly and take enough water. Enough clean water.
Okay. In the next hour, Felaris has something to miss with. This whole conversation about sustainability and environmental sustainability and governance, corporate social responsibility.
Wow.
These buzzwords, what exactly do they mean? How do they mean for us? It's 9 a.m. Good morning.